Hi there, I'm Sarah Pavanka and I live in Charleston, South Carolina. I have two daughters, and my younger daughter had a combined kidney and liver transplant almost 15 years ago this June. Like so many of us here today, COVID has been a huge worry to our family, and it's been hard to know how to navigate it in a household with a transplant recipient. I want to welcome you to this session today entitled COVID Update for Pediatric Transplant Recipients. I'm really happy today to introduce you to three physicians who have been working really hard to help navigate COVID these past 2+ years. Here's a bit about each of them. Dr. Taylor Heald-Sargent is a pediatric infectious disease doctor at Lurie Children's Hospital. Her clinical focus is on children undergoing transplants, and her research focus is on prevention, monitoring, and treatment of viral infections in transplant recipients. Dr. Heald-Sargent is part of the Pediatric Transplant Conference Planning Committee, as Melissa said, and we are so delighted that she is here today to bring us up to date on COVID. Then we'll also hear from Dr. Joseph Spinner, a pediatric cardiologist at Texas Children's Hospital, who specializes in the care of children with heart failure, cardiomyopathy, children who've undergone placement of a ventricular assist device, and children who have undergone a heart transplant. He will share with us the findings of a COVID research study that he's been conducting at Texas Children's Hospital. And then finally, we'll hear from Dr. John McAteer, a pediatric infectious disease specialist and nephrologist at Johns Hopkins University. Dr. McAteer has a research interest in vaccine responses of children who've undergone solid organ transplantation. He will guide us through the findings of a pediatric COVID research study that's being conducted at Johns Hopkins University. We are really excited about this session. If you have questions, please add them to the chat, and we will make sure that either they're answered there in the chat or live at the end if we have time. So let's get started. I'm going to turn it over to Dr. Heald-Sargent.
Hello, everyone. Thank you for having me. I'll put up, I think I can share my screen. Okay, so you guys can hopefully see my slides now. Someone shout at me if you cannot. Thank you for the kind introduction. I'm Dr. Heald-Sargent from Lurie Children's Hospital. I'm an infectious diseases physician, as was mentioned. So I, this morning, would like to just give you a brief update on what's going on and some of the things that I kind of find confusing. Hopefully, I can at least introduce you to and maybe show a little bit today. So my goals for today are not necessarily to tell you everything, all the data, and bring you, every latest study on what's been going on, but really to familiarize you with some of the terms that you might have come across, some of the options that might be out there for preventing and treating COVID-19. I will say there's not much data out there right now still about the outcomes, because a lot of them anecdotally seem to be kids with transplants do okay. It depends mainly on their comorbidities, so other things that are going on. So really trying to keep kids healthy as possible is the best thing going into it, staying on your drugs, preventing rejection, all of that. But I did hear through the pipeline that there is a multi-center bigger study that's under analysis right now on outcomes in transplant kids. So pay attention to that, hopefully in the summer. So on to what we can talk about. These are all things I am sure you guys are familiar with. Various non-drug or non-pharmaceutical interventions. These are what things we had to protect us early on in the pandemic. We could do them right off the bat. Some of them are easier than others, such as washing your hands, as opposed to wearing a mask. Oops, I forgot mine today. Or cleaning the house, as opposed to installing a whole new ventilation system. But even though some are easier than others, they all have different levels of effectiveness, and we should try to incorporate them into any strategy we can do. Now, a lot of questions have been asked about masks and how much masks work. And there was a study that surprisingly was able to actually get at this question, because it's a really hard thing to figure out which one intervention might have an effect. And they actually were able to show what most people assumed, which was N95 masks, KN95 masks worked best at preventing transmission of infection. And so if you can, wearing those masks is the best protection you can afford yourself and your child. Remember that the thing that's really important is that you have a tight seal all the way around. I know I bought a bunch of them online, and when they came, they just didn't quite fit my face right. And so I had to maneuver them and everything. When we wear an N95 in the hospital, we have to go through yearly fit testing to make sure our face shape hasn't changed, gained weight, new facial hair, to make sure we have that good fit. So that's just something to keep in mind if you are going to go that route. Otherwise, that surgical mask, the reason why they recommended putting a cloth mask over a surgical mask was, again, to keep that tight fit. So when you put on your mask, any mask, just make sure you're trying to keep the big areas of air movement closed as possible so that the air goes through the mask. Okay, and something just to reassure you guys is that if you do use even just these interventions, of course, vaccination also helps, and that was part of this study, but using the testing and the cohorting and the isolation and the masking, they found that even when someone was infected with SARS-CoV-2 at a summer camp, that it didn't spread. They were able to control that. So we can start to, take risk mitigation factors and start to live some of our lives again and not just live in this fear bubble that we had to, because back in the beginning, this is all we had. And when we're in infectious diseases, we like to think about all the tools in our toolbox and everything we can do to try to prevent infections. But that's kind of it's not a universal analogy. So thinking about kids and what they might understand a little bit better, I tried to come up with a different analogy, and actually I had to turn to my daughter to help me. So if any of you guys are familiar with Minecraft, these are creepers. And if you're not familiar, you can learn about it now and then be ready to sign up for tomorrow's Minecraft session for the Kids Day. Or if your kids are into Minecraft, there's a Minecraft Roblox session tomorrow that you should sign up for, and you have to sign up for Kids Day separately. Anyway, so I've nicknamed these guys the COVID creepers. Creepers typically come out at night and basically they hurt people. Not great, but kind of similar to COVID. So these are the COVID creepers, and this is what someone might look like, full of health before they're infected with the virus or exposed to the COVID creepers. But as soon as those COVID creepers come along, they might make this person sick, and all their health bubbles or health hearts. I've been told, by the way, there's supposed to be way more health hearts, but this is my graphics. So I apologize to any Minecraft fanatics out there for my errors. But anyway, so when the COVID creepers come, they might hurt you. So how can you protect yourself? And those non-pharmacologic, those non-drug mechanisms are the first way. And that's like kind of building a wall, trying to prevent the infection from getting to you. So you can use washing your hands or cleaning and disinfecting or monitoring people that you're going to come in contact with, asking them, hey, have you been sick lately? If you're sick, stay away. But in addition to just doing those things, you can use those upgrades. So wearing a mask, and these upgrades might be harder, like testing. Not everybody might be able to get it, although luckily it's much more available now. I was able to go to the store and pick up a couple last night over the counter, really easy to get, and even not even over the counter, just out there on the shelves. So these are becoming easier and they're enhanced, they're better. So your wall is getting stronger, preventing those COVID creepers from coming in. But they can still get in. There's holes in that wall, and there's, things that could allow them to sneak in or break the wall. So adding on to that another layer, being social distancing, can help. And that definitely minimizes your risk. But I still think there are more things we can do. And so thinking about what we can do, obviously plugging that hole in the wall, but also giving that person a way to protect themselves, some sort of weapon. So we can do that by helping our immune system be prepared to fight that virus. So that would be through two ways: passive immunization and active immunization. So passive immunization is not an immunization that you might think of when you hear the word immunization. It's just taking someone else's antibodies or antibodies that were made in the lab and giving them to a person. So it doesn't have to do with like giving a shot and tricking the body or anything. This is just giving them the antibodies. And we have one product out there where it's an antibody that's been created in the lab, and it's been modified to last a very long time in the body, like months. And so we can give it to people before they've been exposed, and that will hopefully protect them for months to come. And this is called a pre-exposure prophylaxis, or PrEP. And the product is called Evusheld. And if any of you had kids when they were younger, little babies that were at risk for RSV, or respiratory syncytial virus, some people might have gotten a passive immunization called Synagis, which is very similar to this, except for it's targeting RSV. And the idea is that then you can get protection throughout the season if you give them the antibodies before. And so this is some way that we can arm our bodies. We can give them not only a way to plug that hole and hopefully prevent some of the creepers from coming and getting us, these COVID creepers, but then once, if we do get infected, we have a sword. We're able to fight them off. We have something in our immune armamentarium to do some damage if they get in. But what about upgrading, bringing it from that dirt or that wood all the way up to some steel, metal, rock? And that's where that active immunization comes in. So where we actually teach the body how to fight the virus. And so instead of just giving them the antibodies, we teach the body to make the antibodies. And this is done by giving a piece of the virus, either through RNA or proteins. Right now, it's all mRNA vaccines, but there's other types of vaccines. And these are the more traditional vaccines you think of. And this illustration, it shows a virus coming in, but really it's just a part of a virus or proteins from the virus. And that stimulates your immune system through those T cells. And you'll hear about these later in the next two presentations that talk more about immunizations. These T cells are really important for this response because they help those B cells to make antibodies. They also help other T cells kill infected cells. So T cells are crucial for this response. And then these B and T cells can go on and have memory so that if you see this creeper or this COVID or this pathogen, whatever it is in the future, your body can react faster to it. So it's even better than that passive immunization. This active immunization is really a step up. So now we have pretty good layers of protection. We're able to help ourselves really fight off these COVID creepers. And this seems like, a great plan. But what about if there's a poor response to a vaccine? Or you do have decreasing immunity over time, or there's new variants and the creeper changes a little bit and it can sneak through some of our protections. So basically, we need some ways to protect ourselves if we get infected. But until that point, we do have really strong interventions here. And I just tried to put them all on one slide and to remind you guys that there are different factors we have to consider which we should use. So the passive immunization is only for the larger, older kids, but the active immunization hopefully will be available in the youngest kids soon. Fingers crossed after that announcement yesterday from Moderna that less than 5 will be coming. It's really promising. So if you get infected, if someone gets infected, what can we do? There are two main ways to help someone. And one way is through helping the immune system, and one way is from fighting the virus. So let's help the immune system. Let's strengthen that sword that the vaccine or the passive immunization already started to create. And we can do that through monoclonal antibodies given after the patient has already tested positive. Now, there are a lot of names on this slide, and I'll tell you, I don't know how to pronounce most of them. We call them Regeneron, as you guys might have heard of, or Bam-Edi is another one that we talk about. And you don't need to memorize everything on the slide. This is just to let you know that there's a lot of options and they change based on your child's age, their weight, and also what variants are currently circulating. Some of these might work against Omicron, but they might not work against the BA2, which is the one that's coming up now. And you're not expected to know that. The important thing is just to call your transplant team and see what options are available for you and your child. And then also to know that you should not modify your immunosuppression on your own. Although we want to help the immune system as much as we can, I'm sure you guys all know we can get into more trouble if we start mucking around without talking to the transplant teams. So taking it one step further, we also have kind of a secret weapon now that didn't even exist when the pandemic started, which are these antiviral medications. And these are two of the more used antiviral medications that I've listed here. And they're kind of like TNT, which I've learned can kill creepers by blowing them up. So the two main antiviral medications that we use, one is remdesivir, which you might have heard of because we've been using it for years now. And actually, it was just approved this week for post-exposure prophylaxis. So if you know someone has been exposed and they're at high risk for getting the infection, you might be able to get this, but also for treatment, even down to tiny little babies, 28 days old, 3 kilograms, small ones. But it's IV only. So we have to give it to you in an infusion center or in the hospital, and it's usually a couple of days. So it's a little hard. There's a more attractive option in terms of ease of administration, which is called Paxlovid. And this is an oral agent. It's only for the larger kids again, but it has a lot of drug-drug interactions. So even if, say, a pediatrician or your primary care provider said, hey, I want to try this drug, if you're on other medications, especially transplant drugs, talk to the people who prescribe those medications first. Talk to your transplant pharmacists or have your team talk to them to see if it's safe, because there have been instances, especially in adults, where they've been prescribed these drugs, not realizing the really severe interactions you can have. So it's a great drug, but has some drawbacks. So again, always talk to your transplant team. in summary, my take-home points for this is that I wanted you to understand that there are different levels of risk and different levels of protection, and it's kind of a mix and match and how comfortable you feel using these and what you can feasibly implement, and trying to combine these because we want to build the wall, but we also want to prepare the person. Be aware that there's going to be updates to the immunizations. I know everyone's sick of hearing boosters and another dose, and it gets very confusing. Just talk to your transplant team. They will stay up to date on it, so you don't necessarily have to, but expect changes. And actually, the two next speakers will talk about why some of those changes will come about because they're actively investigating these vaccines. And then again, if you are your child or you are exposed, or especially if you test positive, even if you're not having symptoms, it would be worth reaching out to your transplant team because our options for treatment are changing every day. And some of them need to be started early or need some figuring out, like how do we get an IV medication into a person, scheduling wise. So talk to them early about what they want to recommend. So that's all I have for you in terms of an introduction. I'm hoping I'm happy to take questions at the end or in the chat if you have any, but right now I want to transition us over to Dr. Spinner. Dr. Spinner was unfortunately not able to join us live today, but he did send us a presentation that is recorded, and we'll start now talking about his trial down at Texas Children's.
Good morning. My name is Joseph Spinner, and I'm a pediatric heart transplant cardiologist at Texas Children's Hospital in Houston, Texas. I want to start by apologizing for not being able to actively give this presentation, but I do hope to be able to participate in the chat during the session. I also want to say how grateful I am to be part of Transplant Families Now, and I want to thank all of the organizers for this great conference and to give me this opportunity to speak about COVID vaccination in our heart transplant patients. I think it is always important when talking about this particular topic to mention any possible disclosures. First of all, I do want to mention that I am not an infectious disease or vaccine expert. I am a cardiologist. However, I know there are some really outstanding infectious disease experts participating in this session, as well as others throughout the conference who can hopefully help us address any questions that you might have. I also want to specifically mention that I do not have any financial or any other type of relationship with any vaccine companies. I should also mention that I am biased. I believe vaccines are safe and very effective. I also want to let you know that I practice what I preach to my patients. So I'm not just telling you guys in clinic or during this presentation that you need to get the vaccine or ask for you to participate in a study. I do follow my own advice. Here's a photo of my two young daughters who are actively enrolled in the Pfizer 6-month to 5-year-old COVID vaccine trials. And both my oldest daughter and I have done some publicity on behalf of the hospital to try and promote COVID vaccination in our community. Okay, now that I got through all of that, I want to let you know what I plan to talk about. I will say a little bit about COVID vaccine effectiveness in adults who've undergone a solid organ transplantation. Then I will share the results of a study we did measuring COVID vaccine antibodies in pediatric heart transplant patients at Texas Children's Hospital. Now we'll wrap up by sharing what we are doing at Texas Children's Hospital now in terms of COVID vaccine and then some advice. So first, let's discuss what effectiveness means. There have been a number of research studies now done on adult cancer patients and adult solid organ transplant patients. In fact, we could take up an entire hour summarizing all of the adult studies and still not have covered a fraction of them. And the problem is effectiveness means different things across the different studies. So this is very, very confusing. And understandably, both families and the medical providers have a lot of questions. There are lots of different types of antibodies. Which ones are they looking at? Are these antibodies the type of ones that we call neutralizing ones? And what about the antibody levels? How high were they? Or what was the cutoff? How long do the antibodies last for? And what about all the other parts of the immune system, not just the antibodies? And the most important question most of us will have as parents or medical providers, is there a test after the vaccine that will tell me if it will prevent an infection or prevent me getting sick and needing a hospitalization? And what if you've already been infected before the vaccine or in between doses? It is all very, very confusing. So I'm going to try and summarize the results of the adult transplant vaccine studies with this one figure from one research paper. On the left is the amount of transplant patients who have a positive antibody test, yes or no. That is before the first dose, before the second dose, before the third dose, and then 1 month after the third dose. After 2 doses, less than half of adult transplant patients had a positive antibody test. However, this did go up to 2/3 of them having a positive antibody test after the third COVID vaccine. So that means that 1/3 of adult transplant patients still did not have a positive antibody test after receiving 3 COVID vaccine doses. The figure on the right actually measures the amount of antibody or the strength of antibody, which goes up with each vaccine dose. The problem is we don't really know what the cutoff value is that is important. Just being positive could still actually mean that the number is really low, like these patients at the bottom, and it's unclear or could give a false sense of security about the level of protection. Okay, so now what about pediatric transplant patients? The following results that I'm going to share are from a research study that we recently published in the Journal of Heart and Lung Transplantation. We tested what are called anti-spike IgG antibodies after the second vaccine. 90 patients had received a 2-dose Pfizer vaccine series, and 6 patients had received a 2-dose Moderna vaccine series. Only 2 patients had received a single J&J vaccine, and their antibodies were checked after that 1 dose. We were able to test for antibodies in 40 of the patients who had 2 vaccines. The average age of these patients was 17 years old because the 5 to 11-year-olds had not yet had a chance to get both vaccines and then get their antibody levels checked by that time. We tested the antibody levels at an average of 4 months after the second vaccine, so not right away. We found that 70% of our patients had a positive antibody test. That means that 30% or 3 in 10 patients had a negative antibody test after 2 COVID vaccine doses. We also measured the different strengths or amount of antibody in each of the patients that were positive. So it was possible that some of these patients had very low levels of antibody at the very bottom, even though they tested positive for the test. And we don't know whether or not they have as much protection as those that had higher levels. So why did some patients not respond? Who were the 30% or 3 out of 10 patients without a positive antibody test? Well, neither of the 2 patients who got the single J&J vaccine had a positive antibody test after their J&J dose. And certain patients were also less likely to respond. Those who have diabetes, those who received a very strong immunosuppression medication called rituximab within 6 months of dose 1. Rituximab is a very strong medicine we sometimes use for children with antibody-mediated rejection or a condition called PTLD or post-transplant lymphoproliferative disorder. And patients who had a very low number of a certain type of immune cell called a neutrophil. This is a lab test that is part of the CBC blood test that all transplant centers routinely test in your child. This can be a sign that they are over-immune suppressed and may not have responded to the vaccine. We did have some other interesting findings. At that time, 7 of those 40 patients who had an antibody test had previously been infected with the virus that causes COVID before getting their vaccines. All 7 of those patients had a very strong antibody response, almost as if they had gotten a booster or additional dose compared to the other patients. There was some concern that certain medications like mycophenolate, which is also called Cellcept, or sirolimus, which is also called Rapamune, might affect the antibody levels or the ability to respond to the vaccine. They did not affect the antibody tests in our patients. Also, every single pre-transplant patient on the waiting list who got 2 vaccine doses before heart transplant all still had their antibodies 1 month after getting their heart transplant, and they did not go away. What about side effects? One specific one that people have been worried about is something called myocarditis. Not a single one of our patients had this complication. Now, we only had about 100 patients get the vaccine at that time, and this is a very, very rare side effect. But it was good and hopefully reassuring to all of you to see that none of our waitlist children, including kids who have had myocarditis before, or our post-transplant children, had this side effect. What about other possible immune system side effects? There has been some concern that getting actively infected with the virus could wake up or stimulate the immune system more than we want it to. So we wanted to make sure that the vaccine did not do that. Only 2 out of the 81 transplant patients who got the vaccine had an episode of rejection within 4 months of the vaccine. Unfortunately, both of these patients had undetectable drug levels and had previously had rejection when not taking their medications. So we do not think that the vaccine had anything to do with causing the rejection that they had, and unfortunately was probably related to not taking their medications. I know everyone will want to know, what about actually preventing infections and hospitalizations? That is the effectiveness part that we always want to know and ask about. Only 1 vaccinated patient out of all 81 vaccinated patients got briefly hospitalized because of COVID. This particular patient unfortunately had a lot of risk factors for not responding to the vaccine and for getting sick. And it was not actually a surprise to us that this patient did not have any COVID antibodies after 2 vaccines. I also want to point out the most important part of this slide. All of this happened right before Omicron. So as with every new variant, it's really hard to know what the effectiveness against a previous variant will mean for the effectiveness against new variants. Okay, now that we summarized our study, what have we learned from this and where are we going from here at Texas Children's? We are actively trying to vaccinate all of our eligible solid organ transplant patients. This table is for ages 12 and up. We have given a lot of COVID vaccines. And as you will see, we are now also giving out the 4th dose for all of our kids over 12. As a heart transplant person, I am proud that we've gotten so many already a 4th dose, and we are now working to get the other organ groups to catch up. And since this was through March, we probably already have many more patients who've moved up a dose on this table. The reason why there are so few lung transplants on this table is because lung transplantation is actually quite rare, so we have very few lung transplant patients. This is now for the 5 to 11-year-olds. Since the 4th dose has not yet been approved for these kids as of yet, we are doing 3 doses only for the 5 to 11-year-olds. In total, we have vaccinated over 450 transplant patients. I am very happy to say that we have seen 0 cases of myocarditis and 0 cases of any other adverse or serious side effects. I unfortunately can't tell you the antibody levels after the 3rd or 4th dose yet. That is soon to come. We're still waiting for all of our 5 to 11-year-olds to get vaccinated and get their blood drawn. And we are actively studying the Pfizer COVID vaccine in our 6-month to 5-year-old transplant patients. So with all this information, what should we do? This was a research paper written by some very amazing and prominent infectious disease experts from last summer, but it still holds true today, and I agree with it. We still need to study how all the strong immune suppression and rejection medications may affect our child's ability to respond to the vaccine, so we know whether or not we should wait or give the vaccine in those cases where someone is receiving these strong medications. We are strongly recommending that all of our patients who are over 5 years old get the vaccine, and we are encouraging all of their parents, grandparents, and any family members who are in close contact to get vaccinated to try to protect our patients as well. And lastly, and importantly, we are not reducing immune suppression medications in any way in any patient before getting the vaccine. It is important that we do not increase the risks of rejection by doing that. So these are our recommendations. We are trying to vaccinate all eligible pre-transplant and post-transplant patients. For the 5 to 11-year-olds, we're giving them 3 doses. For those that are 12 and up, we're giving them the 3-dose series plus a 4th dose, and we're calling that 4th dose the booster. We're not making any changes to the immunosuppression before the vaccine. And anyone who's recently received a really strong infusion of a certain type of immunosuppressive agent for rejection, we are likely to wait at least 4 to 6 months, but that depends and is patient specific. We are encouraging all eligible household contacts and family members and friends to please discuss vaccination with their medical providers to add more protection for our patients. And lastly, and most importantly, I believe that you should all ask and discuss vaccination with your transplant team at every appointment. I want to take another moment here to thank all of our patients and their families for participating in these types of studies, whether to study vaccinations or new immune system medications. We really appreciate when you do that. It is really so helpful for all of our transplant families. I also want to thank my team at Texas Children's, who are really just amazing. Our staff has been really on top of getting our kids in for their shots and reminding them when they were due for a vaccine. We have two outstanding transplant infectious disease experts, Dr. Bikini and Dr. Munoz, who helped me with this vaccine study. So I wanted to thank them. And lastly, I want to thank all of you very much for your time and attention. Please feel free to reach out to me if you have any questions. Thank you very much.
All right, great. Hi, everyone. My name is Dr. McAteer. I'm one of the infectious disease fellows at Johns Hopkins, and I want to thank everyone for having me. I also want to thank all the organizers for making this conference possible. I'm honored to discuss COVID-19 vaccinations with you as a member of the transplant families. As part of my talk, I was asked to review our most recently published paper in the American Journal of Transplantation, where we studied antibody responses to the Pfizer vaccine in pediatric solid organ transplant recipients. And as you can see by the number of authors and institutions involved, this was a nationwide collaborative effort. I'm very humbled to be a member of such an incredible group of pediatric researchers. These were the disclosures from the authors of the paper. And I personally do not have any conflicts of interest to disclose for this talk. Like Dr. Spinner, I'm also a fierce vaccine advocate, and I also practice what I preach. I have a fully vaccinated 10-month-old at home, and I have intentions of having him vaccinated against COVID-19 when he is eligible, which actually sounds like it might be pretty soon based on the most recent headlines. So background for this study, we do know from the adult literature that adults with solid organ transplants do have worse outcomes when infected with COVID-19. And specifically, regardless of the variant, there is a higher rate of mortality, hospitalization, and specifically acute kidney injury and kidney failure. Additionally, adults with solid organ transplants have impaired antibody responses to the COVID-19 vaccinations, like Dr. Spinner mentioned, when compared with adults that do not have solid organ transplants. And as Dr. Spinner also mentioned, studies have generally agreed that about a third of adults with solid organ transplants do not have detectable antibody levels after receiving an appropriate vaccine course. And this makes sense because these patients are considered immunosuppressed because they are taking their anti-rejection medications and thus cannot mount an appropriate immune response to either fight off infection or develop protective antibodies after vaccination. In children, however, it does not appear that COVID-19 infection is quite as severe in adults, even in immunosuppressed patients. And there's thus a need to better understand the immunology behind COVID-19 infection in children, as well as vaccine responses in this population. Specifically, as part of our study, we wanted to study the differences in immune response, as well as understand the safety of the vaccine in children living with solid organ transplants. So this was the objective of our study. We wanted to assess antibody response and safety of 2-dose Pfizer mRNA vaccine in the adolescent solid organ transplant recipients. So our study included those that were 12 years or older, and this was done at the time because this was the only pediatric group the vaccine was approved for. We do have a separate study ongoing right now that is looking at the 5 to 11 age group, and we do plan on doing children less than the age of 5 once that is approved as well. So our study design, we conducted a prospective observational study. So basically what we did was we took a bunch of patients and followed them over time. And this was from April to September of 2021, which primarily coincided with the surge of the Delta variant. We measured antibodies to the anti-spike protein receptor binding domain. And we measured these antibody levels at baseline, 30 days after the first dose of the vaccine, and then 30 days after the second dose of the vaccine. And this is sort of a graphical representation of the study design. So as you can see, we tested antibody responses at baseline, and then we also had a baseline survey, and then we gave the dose of the first vaccine and had a survey questionnaire that looked at side effects, hospitalizations, organ rejection, and then we measured antibody responses 30 days after the first dose and then 30 days after the second dose. And it should be noted that patients could join the study at any time, regardless of where they were in their vaccine schedule. So our study population, so these were the members of our study. There was a total of 57 participants from all across the country. The median age was about 14 years of age, and it ranged between 12 to 18-year-olds. It was predominantly female and mostly consistent of Caucasian participants. The median time since the transplant was about 10 years, but this ranged anywhere from 5 to 13 years of age. The most common transplanted organ of participants in our study was liver transplant, followed by heart and kidney. And it should be noted there are very few multi-organ transplants included in our study. So this is a graphical depiction of the results of the study for each of our patients. So these are all antibody levels. As you can see, baseline as well as 30 days after the first dose of their vaccine and then 30 days after the second dose of the vaccine. So as you can see below in the left bottom here, about 57% of patients had detectable antibody levels 30 days after receiving their first vaccine. And then after the second dose of their vaccine, this number actually increased to 73%. And as you can see also in the bottom, the actual number, the unit of antibodies actually also increased pretty significantly. It should be mentioned that the actual protective effect of these antibodies is not truly known, especially in this patient population, and thus a threshold for protection has not really been established. But what our study showed is that these antibodies are produced in about 73% of patients after receiving their second dose of the Pfizer vaccine. We also looked at any factors associated with having a negative response, even after receiving the second dose of the vaccine. So these patients did not have any detectable antibodies even after receiving 2 doses of the vaccine. So this table right here shows that the time to transplantation was a factor associated with a negative response. So in other words, the closer to transplant you were, the less likely you were going to develop detectable antibodies after the second vaccine. This was another slide. We also found that patients on multiple immunosuppressive agents were found to be less likely to respond after the second dose of the vaccine. So as you can see here, as we go from 0 to 1 to 2 to 3, the more immunosuppressive agents you're on, the less likely you were to develop antibodies after the second vaccine. Additionally, we also studied specific immunosuppressive agents, and we found that those on an anti-metabolite medication, such as mycophenolate or Cellcept, or azathioprine or Imuran, were less likely to have detectable antibodies 30 days after receiving the second dose. We had 2 breakthrough infections during our study timeline. It was reassuring because both cases only resulted in mild symptomatic infection and did not result in any hospitalization or rejection. One patient was diagnosed between the first dose of the vaccine and the second dose, and the second patient was diagnosed 1 month after the second dose of the vaccine. And this patient continued to not have an antibody response even 3 months after the second vaccine. But we had no hospitalizations among patients in this cohort. We also studied side effects and safety of the vaccine. So these were the most common side effects reported in our pediatric population of solid organ transplant recipients. As you can see, injection site pain, fatigue, and headache were pretty common, and fatigue and headache seem to be a little bit more common after the second dose of the vaccine. And we did note there were no adverse events to the vaccine reported. So we didn't see any allergic reactions. We didn't see any organ rejection. We also did not see any neurologic conditions. And reassuredly, just like Dr. Spinner's study, we saw no cases of myocarditis in our cohort as well. So that's very reassuring. So this is our summary slide of our study coming out of Johns Hopkins. So our study showed that about 73% of pediatric solid organ transplant recipients developed detectable antibodies 30 days after receiving the second dose of the Pfizer vaccine. So we do suspect that children are probably able to mount a more robust response to the vaccine than their adult counterparts. We did find that risk factors associated with a poor vaccine response included a shorter time from transplantation, use of multiple immunosuppressive agents, and then if you were maintained on an anti-metabolite medication such as Cellcept. But our results do suggest that the Pfizer vaccine in pediatric solid organ transplant recipients are safe, and they do produce an antibody immune response. So limitations of our study, again, this was only a very small sample of children and obviously does not represent the entire pediatric solid organ transplant population. The other limitation to this study, and it's kind of a big debate in the vaccine community right now, is if these antibody levels actually correlate with neutralizing capacity, so ability to sort of neutralize the infection. And then also, the study was performed mostly during the Delta variant and may not be entirely applicable to the Omicron or the other future variants. We are planning on studying responses to other arms of the immune system in terms of like future directions for our study, because we know besides antibodies, there are also T cells and other ways your immune system can help prevent COVID infection. So we want to study how the vaccine actually affects those different arms of the immune system. And then we're also having other cohorts of younger children. So the 5 to 11 group we're studying right now. And then we're going to do even younger once the vaccine has been approved in that population. And we do have preliminary results that we have another paper that was accepted for publication in the American Journal of Transplantation, where we actually looked at vaccine response after the 3rd dose of the vaccine. And antibody responses a month after the 3rd dose of the vaccine was very high. It was about 88% of patients responded after receiving 3 doses. So that's really reassuring. So our recommendations from this study and sort of what everyone else touched upon, we do recommend following the CDC recommended guidelines for vaccination in immunosuppressed patients. We do encourage all eligible close contacts to become vaccinated against COVID-19 if they're able to. And always discuss vaccine strategies and COVID-19 treatment strategies, because this data comes out very quickly and it changes very rapidly. So it's always important to sort of discuss with your transplant team if you have any questions or concerns. So these are my references for this talk and for the paper. I do want to acknowledge, again, this research is not possible without the support of the participants and their families, just like you guys. And these were the grants that provided funding for our study. And I want to acknowledge our research group. So this is the Epidemiology Research Group in organ transplantation at Johns Hopkins. And I really want to thank everyone on this list for all their hard work and dedication to this study. And I also want to thank specifically our founder, Dr. Segev, who founded this amazing organization.
Great. Thank you so much, Dr. McAteer and Dr. Heald-Sargent and Dr. Spinner. We have a lot of questions coming in through the chat. And since we have you live here, Dr. McAteer, can I ask you one of them? There's a question about an 11-year-old who doesn't qualify for the 4th booster, but is turning 12 next week. Should they get a booster at 5 months after the initial 3 shots, or stay on the under 12 track?
Yeah, we actually had a patient in our nephrology clinic, and we sort of had that discussion as well. I think I would consider them probably a 12-year-old at this point. But again, I don't think there's really much data on one way or the other in terms of that. So I think you could talk with your transplant team, but I think I would kind of treat them the age they're kind of going into. So, but again, there's really not a lot of it has been a question that's, I think, starting to come up now that, people are sort of in that strange age group. But yeah, I don't know if anyone else has any thoughts.
Yeah, we've pretty much just said whatever age you currently are to go with that vaccine. That because, like Dr. McAteer said, there's just limited data, so we have to go with what's going to
Okay.
Probably not your answer for a lot of things. There's limited data.
Right. But so talk to your transplant team. That's the best thing you can do. That's been echoed here. Is it too late to enroll in this Johns Hopkins study, Dr. McAteer?
I don't believe so. For adolescents, I think it is, but I think we're still doing the 5 to 11. And then, of course, anyone under 5, we're actually looking for participants. So if you have any children less than 5, we'd be very happy to, provide our email and contact information.
Okay, great. We'll try to see if we can add that into the chat, the contact information. And Dr. Spinner is actually at a different conference, and he's answering questions live in the chat, which is amazing. So if maybe he'll answer that question if he has a chance. I know he's multitasking. We have a couple other questions. Let's see. If a transplanted child gets COVID, should they wait to get vaccinated, or boosted, or should they stay on the schedule that they are supposed to be on?
So I can take this one because I kind of answered some of it in the chat too. It's, again, as always, talk to your transplant team, because a lot of it's going to depend on how severe their infection was. In theory, most people, we've just been saying, as soon as they're out of isolation and quarantine, they can go and get that shot. And I've done that with some transplant kids that have had very mild infections. And we've said, on your way out the door from, coming to see us, go get your shot if they're past that period. But other kids that might have gotten those monoclonal antibodies or had some drugs that might have changed their immune system, if they were really severely infected, they might have gotten something like steroids. Then we might want to wait until those monoclonal antibodies or those steroids aren't going to impact the response to the vaccine. So we want to make sure the immune system can respond well to that vaccine.
Okay, great. And then should we be expecting our kids to continue to be vaccinated against COVID every year and perhaps boosted?
The FDA met to discuss this in theory for everyone not too long ago. They had just an informational gathering session, and they're going to meet again, I believe, in June to talk about actual action items regarding fall immunizations. It's expected that this might turn into something at least this year that we'll need to do another booster for. If that's going to be, though, a booster where it's for a certain variant or a different dose or a different timing, they're going to have to weigh in on that. But I wouldn't be surprised if there's more boosters. And actually, some of the companies are working on combined immunizations, such as flu and COVID, which would be kind of nice and convenient for those of us that have children who absolutely hate getting shots.
Yes, that would be great. It'd be nice. Okay, great. And I think we have time for one more question. Are all centers recommending the 4th booster? So I don't know if that means the 3 doses is the primary series and the 4th dose is actually the booster. I guess that means, are you recommending both boosters, or are all centers recommending, as far as you know, boosters?
I mean, our center is definitely recommending boosters, especially age 12 and older. I'm not sure if I think it sounds like most institutions are, and the CDC guidelines do sort of recommend a booster dose in that age group specifically. So I think we've been doing it.
That was why I deliberately left out the actual vaccine recommendations at this moment, because it could change tomorrow. I mean, you never know. And we recommend whatever the CDC has approved is what we recommend. So as many doses and boosters for that applicable age group, which is often the younger transplant kids might have more boosters than other kids in their age group. And we do recommend them to get all of them when they can, when they're eligible.
Okay, so cdc.gov, go to cdc.gov and look for your child's age to see what the recommendation is. It's a little confusing, but it's there.
Yeah.
And it might change tomorrow. Wonderful. Well, we really thank you so much for your participation and tackling this subject. This is just a burning question for all of us, and you did a great job covering it. So thank you so much to both of you and to Dr. Spinner. I know you're out there. We encourage everyone to, which is side effects of transplant medications or skin issues related to pediatric transplant. There are 2 sessions going on right after this. Thank you so much for being a part of our transplant conference today. Thank you.